So, good morning. Professor Werner is already ready, so without wasting much time, we shall listen to him. He'll be speaking on how to select different wires for anti-grade strategy, tips and tricks. Professor Werner, please.
Thank you very much. Well, the title is How I Select My Guide Wire, because it's certainly a very personal approach how to manage wire selection, and you heard in the first two live presentations different approaches. But there are some basic rules which I want to bring across. Of course, the setup, maximum backup, 2 injections from both sides, and the microcatheter. And finally, you need to know, of course, your wires, and that's what I want to talk about you, but not too much of technical details. There are 100 slide presentations on technical details of wires. It's more about your personal choice and select out of the manifold wire what you want to use. These are the modules of approach, whether you need to call it an algorithm or these are basically what you need. You have IVUS, you have retrograde, you have re-entry, parallel wiring, but the basis and 60 to 70% of the lesions, and you saw just 2 nice examples, are done by the anti-grade wire escalation and sometimes then added with a parallel wire. We know the IJCTO score. The IJCTO score basically describes whether you will be successful with this anti-grade wire approach in a fairly decent time. 30 minutes is the blue bar. If you look at the numbers in the IJCTO score of the individual patients in this category, you find that 45% are in 0 and 1, and you should be able in more than 90% to achieve an anti-grade success. If you go in a center like mine, where I get a lot of referrals, then the easy lesions, 0 to 1, are a little bit less frequent, 28%. So in these lesions, 80% anti-grade success, I'd need only 20% retrograde. But if you have more complex lesions, like in 4 or 5, IJCTO score 4 or 5, then you will end up with 80% retrograde. The wires we have are even ever increasing. Our Japanese colleague at home take already wires that we haven't seen yet, Gaia Next. But what is remarkable is that there was a long time gap between wire development in 97, 98, Miracle, Confianza. Confianza is still around. Then there was a long gap of 10 years until the XT came. And then a shorter period, and now an escalation of new wires, which every wire you have to get familiar with. And of course, you should also discard some of the old wires. Nobody is driving around with an old standard when you have a new Maruti. But there is one thing that also came up in the presentation today already, was the talk about the microchannel, looking for the microchannel. And I must say this is a little bit not really looking at the literature. There's a wonderful paper on anatomy of CTOs from the group of Vermani. And they looked at more than 80 CTOs. And what they clearly state, there are no microchannels that traverse a CTO. So if an XTR or an XT wire passes through a CTO, it will not pass through a microchannel because there is none. But it might pass through very soft tissue because the composition is organized thrombus commixed with calcium, and you will find soft tissue, and the soft wires go through soft tissue, but not through microchannels. This is a very old classic wire. I still use the XT, even though it's almost 10 years, because it's a probing wire, and it doesn't work for microchannels. Here you have a CTO, we even have a MSCT that depicts a little bit of calcium. The CTO starts right at this side branch, and here you see the advancement of the wire. It takes some time. The wire deviates a little bit into the side branch here, but after manipulation of change of the tip configuration, it easily advances into and penetrates this soft cap, and then you get through. Of course, tip shape is the basis of how to manipulate wires. I give you here 4 shapes that I use. This is the regular workhorse configuration. This is the shape when you want to penetrate from a larger lumen into the proximal cap, maybe with a stiff wire. This is the shape, basically, without the secondary bend, how a Gaia looks. That's the wire you work with inside the CTO, and that is the collateral passage configuration. But remember, most of the older wires, Confianzas, Miracles, they lose the shape within a few minutes. So you need to reshape, get the wire out, reshape if you get stuck. Don't change the wire. Look how the shape has developed. So which wire do we need? Everyone has different characteristics, qualities. You need to get familiar with it. There are major technological steps over the past years, especially from Asahi. I think they are the undisputed leader in the technology. They have the Act 1 technology, the composite core, which goes into the Xeon, and Gaia wire construction. But we still have old-fashioned wires around, like the Ultimate, like the Confianza. Some of them we still need, but you should get rid of wires which are replaced by better wires. I don't see any place for Miracles anymore, except maybe for the Miracle 12. So this is my personal selection of wires for the integrate approach. I have the Fielder XT. There is the XTA, which is the modern version of the XT, XTR, Ultimate, Confianza Pro, Pro 12, Miracle 12. Then we need pilot wires. There is a new wire that's actually for the periphery from Asahi, that's the Gladius, and then we have the 3 Gaias. Actually, to make my shelf even more slim, I got rid of the XTA, and I got rid of the Confianza and just have the Pro 12. But I add from 2 other companies, 2 other stiff wires. That's the Progress 200T and the Hornet 14. One from Abbott, the other from Boston. And that's basically what you need. And you may reduce, maybe you go from Gaia 1 to Gaia 3 and skip the Gaia 2. But that is personal preference. All these wires have different tip shape retention. That's what I mentioned. The new wires retain the tip shape much better than a Confianza. Tip load obviously is different. Penetration force, which is the tip load divided by the diameter of the tip, is different from a Miracle 12 to a Confianza Pro 12. Then we have different coatings and torque control. These tables you can look up in the company files, of course, on the increase of tip load, and it's obvious here we start with low tip load and increase if necessary. And the same is true also for other companies' wires, here the Progress family. But torque control was already there before the Gaia came. This is just an old-fashioned example where I try to advance a wire into a circ, which is proximally occluded, and you know circs are often very tortuous. So I start with an Ultimate Pro, and you see the Ultimate Pro takes a wrong path. I could now start parallel wiring, or I take a wire with a better tip control. In this instance, this was a 200T, that is a strong wire. Strong wires have strong tip control. So I could redirect from this wrong direction into this direction. And also in the other plane, you see that I could modify from the false to the proper course and then advance through, which is what you do basically now with a Gaia, but you can do it with a Confianza Pro too. And of course, everybody knows this nice Gaia depiction, where you have demonstration of the torque control. But the main thing is, if you want to apply this, you need to have a clear vision of the distal target. If you don't need where to steer, the whole steering doesn't help. This is a typical example of the Gaia potential. This is certainly not looking like an easy CTO. It's a very long lesion, blunt occlusion. You have some retrograde options here. And I start here, this is the fluoro, with some wires, XT, Ultimate, didn't go anywhere, so I have a Corsair and a Gaia 2. And you see the real-time progress, slow progress working of the Gaia 2 into the CTO. Not much of a direction because the occlusion was very, very long. But you just trust. You go 2 steps forward and you always pull the Gaia a little bit back, because if it's stuck, then it's alarm. You shouldn't go on if it's stuck. And it makes steady progress. Then you confirm by biplane injection here that you are heading towards the lumen, and then more progress, and then you hit the distal lumen. So it's one wire passing a very, very long occlusion with a very nice result. And I thought I need to do this patient actually retrograde. So, which wire to start with? You look at the proximal cap. Is it blunt, tapered? Is there a side branch? These are the different categories to decide which wire to start with. But basically, in most of the cases, I don't look at this. I always start with the XT or XTR, just to probe the cap. Now, if the XT advances into the cap, but then stops, I will use a Gaia 2 or Gaia 3, or if it stops even the Gaia, then I will switch to the Confianza Pro. But if I don't even penetrate, still I will use the Gaia 2 and 3 as penetration, or if it doesn't work, a Confianza Pro. So I increase the wire penetration force. And at every point of advancing with the strong wire, I will try to go back to a softer wire, mostly back to the XT or XTR, to be safe in the distal lumen. But that is basically, you probe with the XT, you decide the next wire, and then you come back to a soft wire. So here, I will start the panel A with an XT and then Gaia 2. Here again, XT and a Gaia 2. Gaia 1 in the C plane, because I think it seems to be less calcified. Here I start right away with a Gaia 2. And here the same sequence, maybe IVUS guidance when you have a cap direct at the side branch, and the same IVUS. And here probably we'll need to go to strong wires. And if you do not succeed, you go to the parallel wire, but we will hear more from Dr. Gohl. So basic rules, I come back, learn your wires. Every wire is as good as your own experience with this specific wire. And that should conclude, and if anybody has holidays in Germany in September, when it's getting hot here, join us in Berlin. Thank you.
Thank you, Professor Werner. Do you think, is there any further improvement in the wire technology?
Well, you could...
you think the Gaia series has reached a ceiling, or you expect further improvement?
Well,
And
we already have the Gaia Next on the market in Japan, not very widely used. And they believe that the Gaia 1, 2, 3, Next 1, 2, 3, will replace the Confianza, increasing strengths. But basically, I'm very happy with the wires I have. Certainly, we need some wire improvement in the collateral side. The SUO is an improvement. But on the integrate wire escalation, we have everything. what I didn't mention is illegal wires, because they are for peripheral use in Germany. It's like the 820 and the 840.
40.
But if you really encounter severe calcium, and that is the main enemy for all our wire manipulation, then probably you'll have to refer to knuckle wiring and getting around the calcium.
Do you think wires that can pass radio frequency energy has any role in this? Hard lesions?
I didn't get that.
Okay.
Can you repeat?
No, the wires which can generate the sparse radio frequency energy in the tip, so that can help in this thing. So like what you use, laser wires.
Oh.
Yeah.
Oh no. Okay. I had similar wires like in the Safe Cross system. Wires that are based on, you mean the plasma wire or the laser wire?
A laser wire, yeah.
Yeah, laser wire I don't think, but of course you will hear something from Dr. Nasu about the plasma wire, where based on a regular wire construction, you apply radio frequency. And that I think is really a very promising advancement in the future. But it's based not on the wire itself, but on using the wire as a transmitter. But the laser will not work because you need optical transmission, and optical fibers will never work like a steel fiber.
Thank you. Any questions
from the audience?
Wonderful lecture, as usual. So it's XTR, then Gaia, and then Confianza Pro. What if there is significant calcium in the proximal cap? Does it alter this frequency? I mean, our priority?
Well, you can, of course, you can only be giving the general approach.
Yeah.
But
yeah.
if you have severe calcium and you see a tapering, then sometimes I will start with a pilot type wire, because it may slide through calcium. So there are options, of course, and certain situations where you have an angulated entry in the proximal cap from the LED. Maybe you use still a good old-fashioned ultimate, because you can nicely shape it and follow with a microcatheter and then go on with the more modern wires.
Okay.
But I think we should get rid of Merkel 4, 5, 6, and whatever.
We also find Gaia finding it's very difficult in calcified lesions. Gaia doesn't really work well in calcium.
Well, it does work in calcium because it doesn't go through calcium, but around calcium. But the very important step is advance the Gaia and pull it back always.
Okay.
And don't advance it 1 centimeter without pulling it, because you can advance it and it gets stuck if you don't realize. And that's when tips of Gaias are left in patients, which there are many around in the world. So always, what I say, 2 steps forward, 1 step back. Then you know that your wire is free. Then you can also work in calcium.
Thank you.
Can we have the next speaker, please? Thank you, sir, for such a good presentation. Dr. Sudhir Rathod, who speaks on antegrade dissection and re-entry techniques.
Thank you. Now, obviously, this is a different concept. I've been requested to talk about antegrade dissection and re-entry and use of knuckle wire technique, step-by-step approach. Now, despite all that meticulous antegrade wiring, there will be some cases, about 10 to 15% of the cases, where the wire doesn't cross the true lumen antegradely after antegrade wire escalation, and the wire enters up in the subintimal space. So there are techniques available when the wire go in the subintimal space to cross the CTO segment subintimally and then re-enter in the true lumen distal to the CTO segment and complete the procedure. Now, if you look at the history of dissection re-entry, STAR procedure was attempted in a series published by Italian operators long time back, which means subintimal tracking and re-entry, but it was not controlled re-entry. It used to be done by a stiff wire distal in the true lumen. Now we have got a dedicated device to attempt the re-entry into the true lumen. Now this device is called antegrade dissection re-entry device, which has got 3 components. So what are the requirements and when should you adopt or when should you apply this technique? So if the antigrade wiring is unsuccessful and there are no retrograde collaterals, then the wire enters in the subintimal space. So you can cross the CTO segment in the vessel architecture subintimally, and there should be an acceptable re-entry zone. What that means is the distal artery should be healthy for the re-entry to be performed. Now the indication for primary antigrade dissection re-entry are obviously what I mentioned previously, and usually the lesions which are longer than 20 millimeter, lesions which have had previous wire failure, or very limited interventional collaterals for retrograde access. Now, coming on to the device itself, it has got three components. The first is a cross-boss catheter, which is a catheter which has got a atraumatic tip, 1 millimeter in diameter. It has got a multi-wire shaft, and it could be spun very fast over the wire or even without the wire at the proximal cap, and it enters the subintimal space deliberately, and you can keep the subintimal space controlled into the distal segment. After crossing with the cross-boss catheter into the distal artery, I will be showing you a case of this, then you can exchange the cross-boss catheter with this flat balloon called a stingray balloon, which sits in the subintimal space distal to the CTO segment, and it has got two ports which are side-on, one at the front and one at the back at 180 degree. So you can align your stingray balloon by contralateral injections to see which way is the true lumen to make the distal entry into the distal true lumen. Now the third part is a stiff wire, which you can see here, which is the 0.014 dedicated wire, which has got a sharp bend to allow you to re-enter into the true lumen and complete the procedure. We have got a Stingray LP system, which is 7 French compatible. You can exchange it with a 7 French system and with an anchor balloon. And this is the over-the-wire balloon, and you have to inflate it at a very low pressure, up to 4 atmospheric pressure. Now, this is how the technique works. As you can see here at the bottom in this cartoon, the cross-boss catheter is advanced first, which takes the subintimal route and goes beyond the CTO segment. And then you exchange this cross-boss catheter with a stiff wire in place with a Stingray balloon, and then you try to make a re-entry with the multiple injections. So how do you do step-by-step ADR? So these are some of the steps. So you have to have a proper setup. Then you have to deal with the proximal cap to enter. Then you have to manage the subintimal space. Then you have to re-enter into the true lumen, and you have to finish the case. So let's talk something about setup. Obviously, you will need a bilateral access, bilateral 8 French or 7 French, but now it is 7 French compatible. You can use bilateral femoral or femoral radial. You need supportive guides. I don't want to go too much into that. So if I just show you my case here, if it plays, and this is a right coronary CTO case, which has been, this was failed antigrade before, because there was an ambiguous proximal cap into the branch, you can see, and there are good collaterals. We could have tried retrograde. I'm sorry, really, this. So you can see here, it's a slightly longer, more than 20 millimeter right coronary artery occlusion with diffuse distal vessel disease. Now, this is not an ideal case for a re-entry cross-boss, because the re-entry has to be performed near the bifurcation because the distal artery should be healthy. So this is the kind of setup you have to take. Now, dealing with the proximal cap, it depends. If the proximal cap is tapered, you can go with the cross-boss directly without using any wire, or if it is less than 20 millimeter, then you can try antigrade wire escalation. But if it is a blunt cap, then you have to have a stiff wire penetration of the proximal cap, enter the CTO body, and then use the cross-boss catheter. And if it is an ambiguous cap, you might have to use intravascular ultrasound to enter the proximal cap. If you can see here, on the left-hand side, I tried antigrade wiring several times, again in the second attempt, but was not able to get into the wire, into the distal artery. Now on the right-hand side, you can see the wire gets stuck here, and he was not able to pass into the CTO body. So the concept of knuckle wire is you try to get the knuckle at the proximal cap, which enters the subintimal space, and cross the CTO segment with the knuckle in a controlled fashion. The Fielder XT and Pilot 200 wires can be used for this procedure. Fielder XT makes small knuckles. Pilot 200 is commonly used to make large knuckles. Now here you can see on the left-hand side, deliberately what I'm trying to do is trying to knuckle the Pilot 200 wire into the subintimal space. Now the advantage of this Pilot 200 wire is when you make knuckle, you have to be in a very controlled fashion because this will not penetrate or go outside the artery and it will take the vessel course. And you can see the course of the knuckle here, that it was difficult because the right coronary artery, you see here, is very tortuous and it has got a double band. That's why we're not able to get into the true lumen. So this is when we have crossed the CTO segment in the subintimal space. You can confirm it with the contralateral injection. After that, we pass the this cross-boss catheter, as you can see here, which is sitting in the subintimal space in the distal artery, and you can see the true lumen is above the cross-boss. The next step is to exchange the cross-boss with a stingray. You usually use a stiff wire like Miracle 3, leave it in place here so it doesn't move, and you exchange with a balloon trap in the guiding catheter, the cross-boss catheter, and then the second step is the re-entry zone. You have to choose wisely in the healthy segment. Some people adopt, you stick in the true lumen and take that wire out and then enter the distal vessel with a pilot wire, or you can use the same wire. Then you can see here we've got the stingray balloon. Now it's very important to align yourself for the re-entry into the distal true lumen because the balloon you can see in two orthogonal views. In one view, as you can see here, you can see this balloon flat, like a winged balloon. You're looking from front to back. And in this view, you can see the balloon end on from the side. So the view to allow the repuncture to happen successfully, you have to see the balloon from side to side. Then one port will be facing in front and one port will be facing in the back. If you see front to front, then one port will be facing towards you and one port will be facing behind you. So you will not be able to puncture in the true lumen when you do the contralateral injection. So the re-entry is performed in the view when you see the balloon end on like this here. Again, if I just show you what that means in a little magnified version, this is looking at the stingray balloon with a flat winged balloon front on from anterior posterior. You can't do the entry in this view because either the wire will come towards you or the wire will go behind you, the artery. Now you have to have a view where you can see the stingray balloon side on. There are two ports. One of these ports will be facing posteriorly. One of these ports will be facing anteriorly. And this is by hit and trial. And when you see the contralateral injection here, you have to go in the port where the wire goes posteriorly. Then you will be able to make a successful re-entry. So as you can see here, we have confirmed that we have to do the re-entry in this view. So we've done the re-entry in the aleocranial view. You can see the wire here. This is a stiff wire, and you can see this wire coming out in the middle of the balloon. So it's not coming at the end of the balloon. There is another port at the end of the balloon, and then you can cross the wire. As you can see, the wire has crossed in the distal artery, which is confirmed by the contralateral injection. And obviously, the procedure is simple after that. Then you take the stingray balloon out, trap the stingray balloon in the guiding catheter, and don't take any injections till this step is completed from the antegrade guide because you've got a subintimal space, and you should always do the injection in the contralateral guide because you might get big dissection in the artery. So there are no injections from the point of start of the procedure till you have done the ballooning and put the stent in. So how to finish? Adequate ballooning before the picture is taken from the antegrade guide. Consider stenting before looking because you know that you are in the distal true lumen before the bifurcation and you are in the true lumen proximal in the artery. And at least when you put the stent, you should cover the subintimal space and a little bit longer to successfully complete the procedure. In the interest of time, I will just show you the picture. I have put the stent after balloon dilatation just before the bifurcation all the way up to the ostium of the artery, and this was the final result. And obviously, you have to avoid re-entry beyond the bifurcation. In those cases, you will run a risk of losing your side branch. So this is step by step how you perform ADR. I will share with you another case with an ambiguous proximal cap. As you can see here, right coronary artery, it was failed before. You can't enter the proximal right coronary artery because there's a branch and you can't see where the cap is. So what we did here, we utilized IVUS intravascular ultrasound in the side branch to identify the proximal cap, and with the stiff wire, we entered the proximal artery in the vessel architecture. We confirmed it here, and we were planning to do the ADR. And then we put the wire further down, as you can see here. into the, and this wire is clearly in the subintimal space. We are not able to advance, but then you see here, we were not happy with that. So this is where we done, this is a cross-boss catheter behind the wire with the pilot 200 wire. And we again did a knuckling, because if you do a knuckling in the artery, it is more likely to follow the subintimal space into the distal artery. If you don't go with the knuckle, it is difficult to sometimes get a proper subintimal space. And the key is you don't take any injection from this point, because you would like to avoid any hematoma in the subintimal space and in the distal artery, and then it will be difficult to re-enter. Then you go with the, now in this case, I was not able to advance the Corsair catheter, the cross-boss catheter. So instead of that, I used a Corsair catheter as a cross-boss catheter in the subintimal space. So I'm very sorry about this, these videos which seem to be causing some problem. So what I did is, because the cross-boss not cathetering, so I exchanged the cross-boss with a Corsair catheter, and the Corsair was able to go subintimally into the distal true lumen to perform the re-entry in the similar fashion. So I think it's not playing. And then what we did when we got the cross-boss into the distal artery, where it is a healthy artery in the subintimal space, what I did was I entered again into the distal true lumen and exchanged it with a stingray balloon, and again tried to do the re-entry, and we re-entered in a fashion where the balloon was side to side and end on, not front to front, and then confirmed with the contralateral injections. And sometimes what can happen in these situations is you can get a big hematoma in the distal artery, and in that case, it is sometimes difficult to enter into the distal true lumen. In those cases, if you don't see the distal artery, you can sometimes aspirate on the stingray balloon to get the hematoma out or take the blood out of the subintimal space, and then you can successfully complete the procedure and get a good result. So I think in the interest of time, probably I will stop here. We have gone through step by step, and I'll happy to take any questions. I'm very sorry about some of these videos which I have not played here.
Thank you, Dr. Rathore. In the interest of time, we move to the next talk. We are already running 5 minutes late. Thank you.
इसी में play करता है.
Okay, friends, so I'm going to talk on the parallel wire technique. In fact, I should have ideally talked before Dr. Rathore, because so you have the antigrade wiring. If it is failing, then you do parallel wire. That also fails, then you go down to the stingray. So when parallel wire, well, when parallel wire, if the first wire is subintimal, or the first wire, the CTO wire, is always going into a side branch, either before getting into the CTO or immediately or somewhere within the CTO segment. Well, so this is what it is. So you have the first wire in the subintima, so you leave it there and you have the second wire, and that is what is the parallel wire technique. Usually this happens, as you saw in the live case today also, at the distal part. Before exiting the distal cap, the wire gets subintimal. So you bring a second wire. This second wire can be brought through a second microcatheter or a dual lumen catheter, which I'll just talk, and then this second wire will go into the distal vessel. So the techniques are, there are two ways to do it. One is you have two microcatheters, or you have something like a Crusade type double lumen catheter. So the first, this Crusade double lumen catheter has an end hole and has a side hole. First, I'll show you the pictures just a little later. The first wire exits the end hole, and it is a monorail system on that. And the second wire exits the side hole, and this is a over-the-wire system on that. So the advantage of a double lumen catheter is you have firstly a coaxiality of approach. So the wires are coaxial. They remain within the center of the vessel or the center of the CTO lesions. They have improved support and penetration force of the second wire, and the second wire maneuverability, maneuverability is very good. So now what if the second wire also gets subintimal? Well, you pull out the first, remove the crusade, leaving the second wire in place, and now use the second wire as a first wire and reintroduce the crusade catheter for a third wire exploration. So that's what you can do. So the principle of parallel wire is leaving the first wire in place gives you firstly a landmark for second wire to be directed in the correct plane. You know where all it is in the correct plane, and you can use it as a landmark. And then only at the point where it's exiting, you then redirect your second wire. Also, the subintimal track created by the first wire remains blocked, and the second wire now can explore a new, possibly correct path. So you will not go into the same track again and again. And the second wires here needs to be stronger than the first, as it certainly needs to penetrate back into the intima from the subintimal space. So this second wire has to be much stronger, stiffer. And the second wire needs to take a more acute curve, because if the first wire is subintimal, you need to have a more acute curve to get back into the intima. So this is what is shown in this cartoon, that the second wire, you see, the first wire is the blue wire which has gone subintimal. So the second wire takes a outer curve and a sharper bend, and then it will come back into the true lumen. And it has to be more penetrating power. And that is how it is to be done. This is the double lumen catheter which I was talking about. So it has a monorail part and it has an over the wire part. So the first wire goes through the monorail part, and the second wire is put through here, and you will exit it parallel. And there is a small gap of about 10 millimeters between the tip and the side port. So the other utilities of this crusade are that it can enter the main branch when first wire is in the side branch, like partial CTO penetration and then side branch exit, or a recanalized CTO and then you enter a side branch by the main wire, or you have CTO of the main branch and the first wire is always in a side branch, or side branch access with first wire in the main branch and you want to enter the side branch, then you can use it. Sometimes you can use the same catheter for a reverse loop entry into the side branch with first wire gone into the main branch, and the side branch has a very acute takeoff. So there's a thing called the reverse loop entry, which is not truly a CTO procedure, but the same catheter can be used for that. So this is a cartoon of how, if your the wire is in the side branch and you want to enter the CTO of the main branch, so you have the double lumen catheter there, and the tip is here, and then the over the wire part with a proximal hole will have the second stiffer wire which will get directed. And so you have two wires and it's a parallel wire. So what are the alternatives to parallel wire once the first wire gets subintimal? You can either use IVUS guided reentry, stingray approach, or retrograde. Well, stingray, we just saw that. So I'll just show you a few examples of parallel wire, a classical parallel wire in CTO. So this is RCA CTO lesion, as you see. So we have a balloon on the side branch as an anchor, and then we are trying to enter into the RCA. And there is this independent wire motion of the wire suggests that maybe it is not going in the right track. And that is what probably had happened. So the wire is down, but now it is, you see it is subintimal. You see it has, distally it has exited subintimal. And so what you need is a parallel wire. So we have the crusade catheter there, double lumen catheter, and now we have two wires, and the second wire is moving just parallel to it, and it is entered the distal vessel. So that is a standard way of doing a parallel wire technique. And the final result. Now this was a patient where we did parallel wire twice. As I told you, the first wire, so this is a circumflex occlusion, with ipsilateral collaterals. So the first wire is antigrade wiring and the wire is subintimal. The distal subintimal location is confirmed by the injection, and we do a parallel wire with crusade. And now the second wire, as you see, well, we have two wires, but the second wire is closer to the vessel, but it is also probably not in the right track, which is Conquest Pro this time. So we work for a third wire in which we have removed the first wire. The second wire is made the first for the second parallel, and then with this, finally, this is crossing. This is the live fluoro for that. So, and you can get a final success. Now, this was a case where wire was always going into a side branch. Now, if you see this, doesn't look like a CTO, you may say, but this is a recanalized vessel behaving like a CTO. So we had a soft wire going down, and it went, but halfway through the lesion, it goes into the septal, and it will not go into the main branch at all. Now I need a stiffer wire. I need a CTO type wire. So rather than losing the track all the way till what I have already accessed, I would use a double lumen catheter, leave this wire in place, use a double lumen catheter, and then use a penetrating technique. So we use the second wire, but initial part itself, it is trying to show a subintimal passage. So we pull it back, and now we have a Conquest Pro through the same, like a wire escalation, and with the parallel technique. And this Conquest is now entering the main vessel properly, and we can complete the case. Now this is a CTO with wire exiting in the side branch halfway through. This is not uncommon. Like you do a CTO, now the CTO of the LAD, so you know there are septals coming out, there's tiny diagonals. So you are working through the vessel, through the CTO lesion. So we have crossed some part of the CTO lesion, and we have exited into a septal. And this exit is again correct. It is not subintimal, and it is correct track, but the CTO has not been crossed completely. So what I would do is maybe do a balloon dilatation, and sometimes it opens the distal vessel very well, and you can really put a normal wire for cross wire. But sometimes that doesn't happen. So in this case, that didn't happen. So the distal vessel did not open up completely in spite of this balloon into the side branch. So we have a double lumen catheter. You see the two markers here distally on the double lumen catheter. And now we have a Conquest type wire, because now you have to use a penetrating technique. And this is trying to enter the main LAD and the final wire location, and we can complete the case. Now, incidentally, this is the last case that I wanted to show. This is actually Stingray. This is not parallel wire, but because it is failure of parallel wire, so I will show you something which he wanted to show, which probably the slides did not work. So this is this case, LAD occlusion. And well, taken up as a standard antegrade procedure. Well, RCA is giving collaterals. Some angioplasty to the RCA also was needed, which was done. That was done. So we have the Gaia 3. Well, with wire escalation, finally we ended up in Gaia 3, and Gaia 3 is going on to the somewhere exiting, which I wasn't sure whether it's diagonal or it is subintimal, because there's a big diagonal beyond, but it was not going in the right track. So I thought we'll use a parallel wire, so we left that wire there, and with a double lumen catheter, parallel wire. But this went subintimal. So this is the final wire location. It is subintimal. So at this stage, I can use a second parallel wire setup, but I thought we will use a Stingray setup. In this Stingray setup, you don't need the crossbars now because the wire is already there. You can balloon dilate this track with a 1.2 millimeter balloon. And so you have two choices, a new parallel wire or a Stingray. So I opted for the Stingray here. And so you do a balloon, 1.2 millimeter balloon dilatation for the Stingray balloon to go down. That's what the crossbars catheter actually does, makes a track for the Stingray balloon to go down. So we just did a balloon dilatation of the entire track subintimally, and then put the Stingray balloon. And this is the double lumen Stingray balloon at the tip here. If you will see, there are two markers, and that's the Stingray balloon. But you are not seeing the distal vessel as well as you were seeing before because of the subintimal hematoma, because of my subintimal wire there, and the subintimal wire passage. So what we do is a straw. That's what the aspiration through the Stingray balloon. And now you see the Stingray balloons in the same place, but the distal vessel is now filling till that level because of the straw. You aspirate the hematoma from there. So you see it better. And once we see it, and in this, if you are seeing the two markers, but without the flat butterfly type shape. So it is on the side, and this is where one side will be in the hole and the other side will be away from the artery. And in this position, we have done this is the re-entry being done. And you can then exchange it to a workhorse wire and complete the case with sequential balloon dilatations. And that was the final result. So incidentally, I have shown that Stingray 1 as a failure of parallel wire. So with this, I conclude my talk. Thank you.
Thank you, Dr. Goel. Just one short question from the audience. We're already running late. Anybody has any pressing questions to ask? VT, quiet, a short question, please.
Yeah. Yeah. Yes.
You have to exchange that because your second wire is in the central lumen. So you have to remove that, use the second wire on the monorail, and then use the central lumen.
If you want, yes, I will tell you. There's very important steps here, because the first wire is coming out from the monorail. And the second wire is not coaxial on the end, it is on the side. So the first wire I will just pull out. I'll just pull out the first wire. Because to handle two wires, it's very difficult to bring back the double lumen catheter. So the first wire I just pulled out. Second wire is now exiting from the side of that thing. So I just pull it out till beyond the guiding catheter mouth and then use a trapping technique. That is very important, because if you don't use the trapping technique, then this second wire will move to and fro in your pulling back, and this little to and fro movement will increase the subintimal space and will get your wire moving at least a centimeter or two, either proximally or distally, which is too much for that CTO lesion. So you have to have trapping. So I will just add one more point there. When you are using trapping for the crusade catheter, trapping balloon plus crusade catheter, you need at least 7 French. So I always do my CTOs with 7
Excellent
French,
point, Dr. Goel.
needed.
I think, VT, we will have to continue discussion at the end of the... No, we have to end over here, sir.
Yeah, I think we
go on
should,
to the next topic.
Thank you.
Thank you, Dr. Goel. We'll give you a big hand. So we come to an interesting talk on the IVUS-guided CTO wiring, how to correlate the angiogram in an IVUS. I'm sure all of us are looking forward to hear this talk from Dr. Sumit Suju. Thank you, sir.
Thank you. I'm going to talk about the IVUS and then the re-entry in the antegrade. But before talking the IVUS, we must know about the more basic part. What is the basic part? That is histopathology. As you know, the many doctors talking subintima. But where is the subintima? Why the subintima is important? And the answer is subintima is space between the media and the adventitia. Media and the adventitia around here, there is a different component, and the media is very special, unique, because the media is, how to say, the uniform contents. That is mainly the smooth muscle cell layers and also only the connective tissue. That's a different from the intimate plaque. Intimate plaque is a very heterogeneous, fibrous, calcified, lipid, la 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 la. So the kind of the points make the media and around the media, that is a easy to be dissection part. Now you can see this is the IVUS. IVUS, black and white border of the IVUS is the EEL. That is not the media, but this is the EEL. So media must locate the inside from this border, and this is the dissected at the black and white border. That means media at the adventitia. Another very important point of the subintima space is outside of the subintima is just only the adventitia and maybe the external elastic lamina. That is very easy to be expandable. That makes easy to make the big lumen here. This is subintima. So sometimes the intramedia and the intima media border could be dissected, but that space not so easy to be expanded because media is there outside of the space. And this is the space that is easy to be expand and sometimes make the collapse of the true lumen. So the wire once coming into the false lumen, not only the false lumen, subintimal space, that is the space between the media and the adventitia. The wire makes the dissection bigger and bigger, and then the blood flow coming. Sometimes the worst scenario is operator do the dye injection. That makes the pressure inside the subintimum increase dramatically, and finally collapse the distal lumen. This is almost all the failure mechanism of the anterior wiring. Okay, so how to avoid it? With using IVUS, that is a good point, good doing. Why? We can anticipate. We never see the media itself in the IVUS. As I say, black and white border is the location of the external elastic lamina. Okay? And the thickness of the media is much, much thicker than this black band. So this black band is not totally equal to the media. That is true. Many, many, many papers, more than 50 papers in the 1990s. At the time of the beginning of the IVUS, many, many doctors do the comparison study with histology and histopathology and IVUS image. And this is true. So please be mind, this is not the media. Media is more thicker. But anyway, media maximum thickness is almost 300 micron. That means 0.3 millimeter. We can see here and here is 1 millimeter. So we can make the possible zone of the media on the IVUS image. How to use it? I'm sorry, this is a different point. This is how to moving the wire, how to control the wire. Wire inside the total occlusion, and if the shaft part of the guide wire is fixed, we can control the wire. And the wire makes the dissection and it goes advance and advance. But once the wire comes into the big space, this is subintima. Wire easy to be moved with a shaft. That means uncontrolled. So this is why the subintima makes a failure of the wire control. Uncontrolled wire movement making a more expansion of the subintima space. Then finally, collapse the distal lumen and finish. So how to use the IVUS information in the angiogram? This is the correlation of the angiogram and the IVUS, but this is very detailed talk, and then sometimes it's not easy to understand in the 5 minutes. But anyway, IVUS is cross-sectional image, and then angiogram is a projection image. Of course, you already know. So we can combine the images with using the overlapping branches, or pericardium or myocardium, the kind of the component. But anyway, after getting the direction information in the IVUS, we can use the IVUS information with the angiogram. And what kind of the IVUS should we use? We have basically 2 IVUS catheters. One is mechanical one, like the Boston Scientific. Another one is a phase array. That is a volcano one. What the difference? The image may be the right now the Boston one, the mechanical one have the more higher the solution, spatial solution because using the more higher megahertz, 60 or something. This is still 30, 20 something. But for the IVAS, for the CTO intervention, volcano IVAS is enough. And volcano have the another advantage, that is this length. This length means the tip to the transducer. Opticross or some other volcano, the revolution, the IVAS capacitor from the volcano as well, mechanical type must have this length longer, 2 centimeters or something. But the eagle eye, that is much shorter, and the shorter type of the eagle eye is much, much shorter. So if you really want to check the cross-section around the tip of the wire, you should use a volcano IVAS. But on the other hand, volcano IVAS need to move the capacitor itself to check the multiple cross-sections. At a time, moving the IVAS capacitor can make moving the CTO system, and then sometimes make the trouble. So I personally like to use a mechanical one, and then bit longer dissection needed, but place it and do not move it. Move the capacitor itself, moving the transducer inside the capacitor, and check. That is my basic style. But sometimes, of course, should not making the advance of the subintimal space. No, force lumen or dissection, at the time, should use a volcano. And then timing of IVAS use. Well, when should we use the IVAS? First one is entry identification. Why entry is important? This is a typical case of the coronary total occlusion in the mid part, almost abrupt, but we can see the one small channel here. So I tried the advanced wire into this channel because I cannot completely say this is a fourth channel. Looks too much outside, but try. And the advanced wire and check the IVAS. IVAS advancing in this side branch. Side branch is not so very big, but it's okay. Good size for the IVAS advancement. So I did the IVAS from here to Proxima. And this is the image. Very important. We can see this is wire. Wire is metal. Metal have the more reflection of the ultrasound. More reflection of the ultrasound makes more brighter signal. That means a white. So this must be the wire. And this big something, of course, must be the main like coronary. And this is side branch. Side branch much, much smaller than this main branch. And the main branch, round shape without lumen. No lumen, no the blood flow, the signal. That means, okay, this is total occlusion. Oh, this is surely we are checking the entry of the total occlusion, okay? And key point is position of this wire. Remember, if the wire once come into subintimal space is around the EL. It may, not a may, it's often makes the subintimal dissection and a failure. So how this one? How is it? Carefully checking. Around here, 1-2 millimeter from the bifurcation, but still this wire is very close to this black and white border. Remember, black and white border and 200 micron, that means 0.2 millimeter something, is a possible zone of the myocardium, media. Sorry. So this black segment is a potentially possible zone of the media. And where the wire is? Oh, already maybe inside the media. That means inside the subintimal, higher possibility of the subintimal tracking. Okay, so of course this is not 100% correct. Sometimes the carina side, media is much thinner. So even looks like this, but going to the disagreement sometimes happen. So I advance a little bit more with the wire, but I already have the information of higher possibility is subintimate tracking. And the wire go out too much, so stop. And what should we do next? Parallel wire, it's okay, but how? Because with using this IBUS image, from the entry, everything wrong. So we must redirect from the entry side. And then I punk, a little bit more inside, and then check the IBUS. Okay, here, this is a much far away from the EL. That means much far away from the media. That is inside the intimate plug. Much higher success could be done with this wire. And then, oh, sorry, I advanced this wire, and there's a, oh, I miss it. But this wire cannot get the disagreement in one time, but I did the parallel wire from using this wire. Because this wire starting with surely inside the intimate plug. And the second wire very easily getting the disagreement. This is how to use the IBUS in the entry side of the total occlusion. Another use of the IBUS is more complicated, but the IBUS guided re-entry. Maybe ADR is much easier and maybe better. I have very small expense of ADR, so because I have the limitation of using the ADR device. Anyway, within the IBUS, even we don't have the ADR system, we can do the re-entry more higher than the just a lucky procedure. So what is the problem? Again, the problem is subintimate tracking. So re-entry from the distal part without the ADR, that is very difficult because there is a tough plug here. So redirect more proximal and get inside the plug, then into the disagreement. This is the key. So one case, this is the case of the LED total occlusion. This wire go to the false lumen, and the IBUS shows more clearly this is the intimate plug. This is the EEL. Here is the adventitia. Probably here is the media. So this space is the media and the adventitia space. This is subintima. This is typical IBUS image of the subintima. And then putting back, branch coming into this intimate plug zone, and this branch also come in here, and then these two branches also connected to this intimate plug side. Not this one, because this is, of course, false lumen and subintima. And where is the point of the wire advance into the subintima space is probably from the this septal. Just from the this septal, the wire is advanced into the subintima. Here is subintima. This is the media. You can see probably. So redirect point is much proximal. And like this, and which direction and how much of the distance from this IBUS catheter. These two factors is very important, okay? Target intimate plug is here. So almost a septal side. And then the length is 2 millimeter from this IBUS. This is, looks some 2 lumen remain here. And even not 2 lumen, but the inside, center of the plug is our target. So how much millimeter? So 2 millimeter and the septal side is downwards in this aurocranial view, and punk with a Conquest Pro 12. And then finally, my wire getting into this 2 lumen. Get the septal, and then again the parallel wire technique, using the showing in the previous speaker, very easily track this 2 lumen, and then finish. So this is a typical step-by-step the using of the intra-region, the IBUS guided re-entry. So this is a method. Key point of the IBUS use is based on the histopathology. So please think about and understanding the histopathologic feature of the coronary in the CTO. And be familiar with the IBUS images. This is another key point to succeed to get in the using the IVUS in the CTO intervention. Thank you for your attention.
Thank you, sir, for this very interesting talk. Most of us are quite behind this IVUS-guided CTO occlusion techniques. Haven't had too much experience for all of us. I know you're coming to some hospitals tomorrow to show us, and we look forward eagerly. If there are any pressing questions, we can invite one question. As I said, we have, most of us have very less experience for this, extremely specialized, and we thank you so much for your inputs.
Thank you.
So I think we mark an end to this interesting session.